Good afternoon, and welcome to today's webinar entitled Virginia's Provisional License Pathway for International Physicians, What You Need to Know. This webinar is brought to you today by the Refugee Physicians Advocacy Coalition in partnership with the Virginia Hospital and Healthcare Association. My name is Sharon Alexander, and I'm the Director of Workforce Initiatives at the Virginia Hospital and Healthcare Association. We thank you for being here today to be part of this discussion. As you likely know, workforce shortages persist and are expected to increase given the growing demand for healthcare workers and services. I am eager to hear more about the new pathway and how together we can help address workforce shortages here in Virginia. I'm joined today by the co-founders of the RPA Coalition, Dr. Sarah Qureshi of Georgetown University School of Medicine and MedStar Medical Group, and Brandy Kilmer, Washington, D.C. Community Program Coordinator at Their Story is Our Story. I will now turn it over to Dr. Qureshi, who will provide us with background on the coalition's work. Dr. Qureshi?
Thank you, Sharon, and thank you all for being here today. I'm the daughter of Pakistani immigrants, and my father was an IMG who redid his residency in the Army and served as the only orthopedic surgeon in a small town in rural Florida where I grew up. I went to medical school with a passion to work with refugee populations and have done so throughout my medical career. Back in 2016 was around the time I was first personally introduced to refugee physicians who were looking for mentoring and any connections in our medical systems. I met one after another and was so profoundly moved by their brilliance, dedication, and resilience. Despite their impressive expertise, they all face significant barriers to resuming clinical practice or using their medical skills in the US. Realizing their untapped potential motivated me to pursue collaborative research, leading to these two publications in 2018 and 2019, which are here on the screen. After 2019, I wanted to do more, but didn't have the bandwidth. It wasn't until I started working with Brandy Kilmer and Sherry Ann Schell from Their Stories Our Story and Ken Spiker from Nova Friends of Refugees, where I found others with a common passion and dedication to action around this topic. We highlighted this issue with Georgetown medical students during their community-based learning course in the fall of 2022. This work led to the formation of the Refugee Physician Advocacy Coalition, a diverse and broad partnership focused on leveraging the skills of international physicians arriving in Virginia to address health workforce shortages and tackle barriers to relicensure. 8 years ago, I could have never imagined what we've grown to today, and I'm so proud of everyone involved in this work and so excited to share it with all of you joining today.
Just a bit of housekeeping. First of all, we want to thank VHHA for co-hosting this event with us, and thanks to those of you who submitted their questions in advance. We won't be monitoring the Zoom chat today for questions, but if you could look in the chat, there will be a link for a Google form to, and we'll address any questions that you have at future webinars or task force sessions in the future. We did not advertise to international physicians, but we've had some register who are international physicians, and so we want to meet your needs as well. So if you if that falls under your category, you can register yourself at the International Physicians Registry linked in the chat, and the RPA TSOS team will be in touch to offer support to you. You'll hear today from a number of medical partners and others who have contributed to developing our initiatives. Although we are in the early stages of implementation, we hope that you'll come away from today's discussion with confidence and a vision for the opportunity the provisional license pathway offers your institutions to grow your physician workforce. And we invite you to help us in developing the implementation models while the Board of Medicine continues its rulemaking. Unfortunately, Delegate Tran, who who was the chief co-patron of this legislation, HB 995, was held up at another commitment today, and she's unable to make it. But we'll hand it over to Mike Zimmer, our partner from World Education Services, to discuss Virginia's provisional license pathway for international physicians. Mike?
Yeah, thank you, Brandy. I'd like to first start off with thanking the RPA Coalition for their amazing grassroots work on this, and especially thank Delegate Kathy Tran for her leadership and perseverance on this issue. She never really gave up in pushing this through the legislature. The provisional license has really three phases to it. Oh, good. Okay. First, and again, this is for the provisional license. To be eligible, a candidate has to have received a doctorate of medicine or an equivalent from medical school on the World Health Organization's list. It's a pretty expansive list. They had to have practiced at least 5 years. They had to have had ECFM&G certification or evaluation from another credential evaluation service approved by the board. And importantly, that may be waived by the board on a case-by-case basis if the country of training and practice is currently non-cooperating. They have to have passed steps 1 and 2 of the USMLEs, and they have to have an agreement with and enter into an employment relationship with a medical care facility that provides evaluation and assessment program. That program, and this is sort of directed towards the medical providers on the webinar, that program has to meet the criteria for evaluation and assessment that is developed and approved by the board. That will be part of their rulemaking. And finally, there's a catch-all in it that said they have to satisfy any other criteria approved by the board, and we have not heard yet that there will be other criteria. Once an individual gets the 2-year provisional license, at the end of that period, assuming the evaluation and assessment went well, the individual is eligible for a restricted license to practice in a medically underserved or a healthcare shortage area. They have to successfully complete the evaluation program. They have to, again, enter into a full-time employment relationship with the same class of medical care facilities, and they have to have passed the USMLE step 3. At the end of that period, the applicant is then eligible to a 2-year unrestricted license where they can serve general practice anywhere without the evaluation and assessment or the medically underserved commitment. Went through that pretty fast, Brandy, but that's the schematic.
Now, just to clarify, you had said after that step 3, they are qualified for a 2-year. It's a restricted license.
Yes, it's restricted by geography. It's not restricted by practice area.
Okay, and then after those
after the end of those steps, you're eligible for full unrestricted licensure.
Okay, great. Can you help us understand, are other states, have they done this previously to Virginia?
Sure. Washington State, and I think we'll hear from them a little bit later, was the first back in 2021. Congratulations, Washington, again. We now stand at 10 states that have adopted the evaluation assessment model. That includes Virginia, so yay for Virginia. By the end of the week, we hope to add another state, 11, that will be Massachusetts. There were 10 other states that had legislation introduced in 2024, and we are expecting at least 15 bills in 2025. So this is really becoming part of a national movement.
Excellent. And a question that was submitted to us is, hoping you can answer this. If the physicians aren't board eligible because they haven't done a U.S. residency, then how would that problem be overcome since the majority of hospitals and practices require board certification?
And by board certification, I think we're talking about specialty certification, not the medical board. The medical board just issues a license. This is true in every state. But various specialties issue board certifications. First of all, in most hospitals, that's governed by their bylaws. And the provisional license period, which lasts 2 years, which is sort of going to be the next step in Virginia, that is typically not viewed as a requirement for provisional licensure. Rather, it's viewed by some hospitals as a requirement for full-time employment. Again, that's sort of a hospital by hospital issue. And At this point, you're absolutely correct. A lot of hospitals require board certification for full-time employment. That's an issue that we are looking at nationally. The Federation of State Medical Boards is also looking at that issue. I can't tell you where that's going to end up, but it is an issue that everybody knows is sort of hanging out there. But right now, absent that board certification, most of the physicians are going into primary care and general medicine.
Thank you. Thanks for clarifying that, Mike, and for your hard work in helping these international medical graduates and addressing the workforce shortage for
Absolutely.
doctors. Thank you. Mm-hmm. And now we'd like to begin the next segment by introducing Dr. Natalie Gospodinoff, a family practice physician from Argentina, to share about her experience seeking to re-enter the U.S. medical workforce. Dr. Gospodinoff.
Yes, thank you, Randy. And good afternoon, everyone. I'm thrilled to be here today and to share my journey with you briefly. First, I want to thank everyone who has contributed to advancing this important license for foreign trained physicians, as this pathway will enable skilled physicians like myself to address the shortage of primary care doctors. So to tell you a bit more about my story, I was born in Argentina into a bilingual and multicultural family with American siblings and a father who had practiced medicine in the US for many years. I earned my medical degree in Buenos Aires, and during my last year of medical school, I had the chance to do an elective rotation here in Virginia. This was my first hands-on experience with the American healthcare system. After medical school, I completed my family medicine residency and served as chief resident. I then continued to serve as attending physician and educator at my alma mater for over a decade. My work also extended to public health, as I was involved in the National Tobacco Control Program, and I completed a postgraduate training in healthcare management and administration. In 2021, my family and I moved to Virginia, driven by a lifelong dream of establishing here and a belief that I could make a meaningful impact in my new community. So determined to continue my career as a primary care physician and knowing that I needed to repeat residency, I set out to meet all the requirements to become a strong candidate. Over the past 3 years, I passed all 3 USMLE steps, obtained my ECFMG certification, and gained US clinical experience to strengthen my understanding of the American healthcare system. I accomplished this while working as a medical assistant to support my family. Currently, I serve as Northern Virginia Regional Tobacco Control Coordinator, where I work in tobacco prevention and community outreach. These experiences have really helped me not only to grow, but to further solidify my decision to return to clinical work. But despite my hard work, securing a residency position has been challenging, and unfortunately, I did not match last cycle. However, a ray of hope emerged when HB 995 passed earlier this year. I was over the moon. You can imagine that learning about this provisional license really renewed my hopes and dreams. Moreover, realizing that I was fulfilling all of the requirements such as the ones that Mike pointed out previously, really encouraged me even more. My experiences in Argentina taught me how to be a dedicated physician and how to positively impact a community, and the important role of compassionate and skilled care. I carry countless memories of patients who have entrusted me with their health, and I'm deeply committed to regaining the role in my new home country. Thank you again for the opportunity to share my story with you today. I'm hopeful that this bill will allow me to return to clinical practice, where I will bring my diverse perspective, cultural competence, and clinical expertise to make a difference in the lives of Virginians, particularly within the Hispanic community. Practicing medicine is not only a career for me, it's an essential part of who I am. Thank you.
Thank you, Dr. Gospodinoff, for sharing your story. And let's turn now to some of our partner contributors who have helped us with some research. I don't see Dr. Hosai Hasham here yet, and so if she is able to join, I know she was in surgery, so if she's able to join, we'll turn to her a little bit later in the program. So let's bring on Dr. Karen Smith. If you, Dr. Smith, thank you for joining us. Dr. Smith, you're with George Washington University, yes?
I'm a
And
professor of pediatrics at George Washington University and hospital medicine physician and medical director of global services at Children's National Hospital in Washington, D.C.
Thank you. Could you share with us what benefits does hiring international physicians via the provisional license pathway offer hospitals?
Definitely be happy to do that. You know, I think Dr. Gospodinoff is just a perfect example of the amazing amount of both experience and expertise and skills that our international medical graduates offer. I do apologize, you know, to our internet, as much as I'd hope, is a little bit unstable, so I'm on the phone as well. So excuse some of the change in that. But, you know, our international medical graduates, you know, as you kind of look at this data that we have here of really the 100 physicians that RPA has worked with, they come with 8 to 16 years experience. I mean, that's a huge amount. This is like different than, you know, getting someone just struck out of medical school. These are well-trained, seasoned physicians that come with a wealth of experience that can easily be put to practice with your patients. And I think also adds to an easier way of assessing and educating and working with them when they're in the provisional license period. I think sometimes as an educator, you think too is, man, this will take up a lot of my time. But here you've got physicians that really know what they're doing, and I think will really be helpful and continue to work and see patients as well. Beyond just being highly skilled and experienced, you know, our international medical graduates really provide this kind of really culturally diverse and resilient era. They're moving to like really match our population. On the graph, you can see where the Commonwealth of Virginia looked in 2000 versus, you know, now about over 20 years later. And there just is an increasing amount of families and individuals that are Latina, and then also from the Asian and Pacific Islander. And a lot of our IMGs really match that. And so you have the opportunity of, here's a physician that looks like me and understands my language, and also the cultural way of how do I respond to healthcare. And those are great, valuable information that can provide help to you and your practices. In addition to that, you know, IMGs, and I'm almost embarrassed myself, I'm Ono language, just one of it, but many of the IMGs speak, you know, on average 3.6, so over 3 languages. And so again, that even saves you from interpreter costs. You've got individuals that can speak and understand, and even in the dialect that our families need. As you know, and as we've heard from the story of Dr. Gospodinoff, you know, there's significant amount of barriers that international medical graduates have to overcome. One, just to get to the U.S. I mean, that's definitely been a topic in the news lately, but a lot of the work to actually get here, and then to be able to continue to pursue to actually be able to practice their medical license. And so they bring that resiliency, that dedication, that drive to their patient care as well. And so also within your organization are going to be amazingly hard and responsive workers and part of your workforce. I think the other, you know, wonderful thing about our international medical graduates, and this is from the AAMC data, they tend to work in rural, low-income, and underserved regions. And that's really important now as we really look in different groups have foreshadowed, you know, what our physician shortage is, both current and that to come. And really look at, you know, we're going to need 17,000 physicians in the upcoming years to meet our primary and mental health care needs. And we've got such this rich talent that's just here, neighbors, that's working at our Commonwealth and areas that We just need to find a way to put them to work, and the provisional license is a wonderful way to get them to working and help them move to having their own unrestricted license and really providing the care that we want all our patients and families to have.
Thank you, Dr. Smith. I see that Dr. Hesham is now here from the Afghan Medical Professionals Association of America. Dr. Hesham, could you share with us a little information about how international physicians' skills compare to the US standards?
Sure. I apologize for the delay. My OR was running late a little bit today. So this is something that I feel very passionate about as I have mentored over 50 international medical graduates over the last 15 plus years and trying to get them to regain basically residency spots and re-enter the medical field here in the US. That being said, commonly we get questions asked regarding, well, how do they compare in terms of their education, in terms of their training, all of those things. And one of the things that we want to look at is not anecdotal evidence and people that we've met, but we want to look at actual data out there. There's some nice studies that have come out recently, and mainly because we're looking at a significant portion of the healthcare force being dependent on international medical graduates. And the UK, for example, and Canada and Australia, where they're way above and beyond us in terms of utilizing international medical graduates, more than 30 sometimes % of the population of the healthcare sector are international grads. In the US, we're looking at somewhere around 25%, but most of these patients, most of these providers have repeated their residency. And places like Canada and the UK and Australia, sometimes they come in with their training from another country. It's been estimated, this is an article from British Medical BMC in 2024. Go back to the slide previously, please. Where they looked into $1.7 billion of savings in medical education costs in Australia alone, and having a direct pathways for these providers to re-enter the healthcare sector and work in underprivileged and underserved areas where there's significant shortage of doctors. Now, moving forward to the next slide. If you know, we're looking at data as early, basically as recent as September of 2024, where we're comparing how international medical graduates are doing to American medical graduates here in performance. Commonly, we're seeing that they're basically outperforming or performing at the same level. Specifically, in September of this year, they looked at outcomes and when it comes to sepsis, pneumonia, congestive heart failure, COPD, UTI, and arrhythmias. And we found that most of the international medical graduates were at the same level, if not slightly better in management of these chronic conditions, both when it came to mortality and also readmission rates. And then moving forward, we're always looking at the cost too. The only thing that was slightly higher with international medical graduates was maybe utilizing some more resources or additional resources in the hospital compared to the US medical graduates. And that may kind of go along with perhaps the evidence-based care that we focus on so much more in the US, and will come in and play once people have been working here long enough and they learn how, how to be more cost-effective and efficient. So that being said, definitely not only are we seeing that international medical graduates are performing at the same level as those who have graduated from US medical schools, but we're looking at the possibility if we're shortening those re-entry paths into the healthcare sector without a full residency, that we could be saving quite a bit of money in terms of that training perspective.
Thank you, Dr. Hesham. And I just want to bring on Jonathan Wolfson from Cicero Institute. Cicero has published some white papers on international medical graduates and the benefits nationally for this. And Jonathan, can you share with us how many international physicians potentially qualify from your studies on the Virginia pathway?
Yeah, thanks, Brandy, and thanks to everybody for letting me be a part of today. At Cicero, we've had the privilege of working with Mike and a lot of y'all across the country on this legislation, have had the chance to work on the Tennessee legislation and a number of other states across the country, and excited to see where this is going. And one of the questions that we frequently get in conversations with legislators is, what's the potential uptake? And so I was looking at the most recent match data from the residency match. And if you look at the most recent year in 2024, there were about 12,000 non-US citizen international medical graduates who applied for residencies, and about 6,000 of them did not obtain a residency. And this is actually a really useful statistics. There were 4,700 US citizen international graduates. So these were US citizens who went outside the United States for medical school. And of those who applied for residency, about 2,200 did not obtain a residency. And so even from just this 1 year, that's 8,200 people who wanted to come to the United States to train, who wanted to practice in the United States, or wanted at least the opportunity to be able to practice in the United States, who were not able to because the number of residency slots has been kept where it is for a relatively long period of time. And so that's not to say that if that Virginia can expect 8,200 people to be in this program, or that the states that Mike talked about, that all these states are going to see thousands and thousands of applications. But if you're a hospital, if you are an FQHC, if you're another entity that under the statutes of the various states that have passed these laws are eligible to sponsor doctors, you have a large number of folks who are ECFMG certified because they're able to apply for residencies in the United States, who have been practicing in other countries for a number of years, who would be eligible for these programs. And so that's a pool of candidates that you're going to have to choose from. And I would fully imagine that the hospitals and facilities in the United States are going to get an opportunity to do a lot of cream skimming and find some of the best people from around the world who would love to come and practice in the United States. And to Dr. Smith's point earlier, these doctors are, the similarly situated doctors are more likely to practice in rural, underserved areas. And so finding folks who may be at the top of their field in other places, like Dr. Hesham, who would be willing to come and serve in places where we might have otherwise a challenge to attract talent, is a really great opportunity for the states that are willing to take this policy on.
Thank you all. And just to speak to that, as I mentioned earlier, we had even though the audience was for medical executives for this webinar, we had international physicians both in Virginia and outside of the state and outside of the country register for this webinar because they have they've been searching out Virginia's legislation and see it as an opportunity. So I think that speaks to the opportunity for employers as well. I had a question for Dr. Hesham or Dr. Smith. Are there positions that hospitals can hire international physicians like Dr. Gospodarov now during the interim period while we wait for the Board of Medicine's rulemaking? It would help prepare them for the provisional license.
So we have actually, with AMPA, we have hired physicians who are either taking the board or waiting for residency to work as patient navigators. That is a very, kind of logical thing to do. And there's been actually conversations that we've also had with a facility here in Washington, D.C., and having them serve as patient navigators in the transplant sector. In addition to that, there's obviously there's always been research that's been a highly utilized area for many, many years. And the research then leads to connections and some clinical experience, which then makes their CVs more robust. But we have also had folks who have used their experience and knowledge and education to go into, for example, informatics or work in pharmaceuticals. So there's a significant use of folks with a high level degree, a very good knowledge of medicine and clinical knowledge, who would be able to work, with a medical team to fill in the needs of a institution. For example, one of the grants that we were working on, we were specifically looking into perhaps aiding folks in getting tuition money to get accreditation for billing and informatics and medical office management. I mean, these are some areas that we are always looking for folks who are talented and have a good understanding of clinical medicine. And for people like this, I think this would be a nice fit. And I'm going to give it to Dr. Smith.
Dr. Smith,
Great.
thank you. Are there equivalents already in place that can help hospitals envision how this provisional license might fit?
Yeah, I think, the international medical graduates really kind of be like a fellow is what I would think about, different than a resident because they've been working and practicing for several years and they have kind of that baseline knowledge and the fundamentals, but it really is going to be helping them just figure out the U.S. healthcare system, looking at that evidence-based medicine of how we manage things, and really just kind of guidance in improving their career. And it also, as you kind of think about what you need the provisional license, you can also use some of those things that you do for ACGME for fellows. How are you going to evaluate them? Competency schedule. That's something that can be easily adapted and used for these physicians on provisional license pathway.
Thank you all for sharing your insights. And at the end of our session, we will share information about how you all might be able to help us with a task force in order to develop the implementation models that might suit your needs at your institution. We'll now turn to our partner from Washington State, Dr. Mohammed Khalif, who has already implemented with the International Medical Graduates Academy and an alternative licensure pathway where hospitals are now hiring. What learnings can you share with us from your experiences there, Dr. Khalif?
Yeah, thanks for having me, Brandy. Really excited to be here and to share our experiences in Washington State. For us, we mainly focused on clinic group practices, clinics, rural clinics, and long-term care facilities when it comes to post-acute care, geriatric medicine, and primary care clinics that are not hospital affiliated. We haven't gotten anybody actually in hospitals because hospitals bylaws usually require that IMG's international medical graduates with this license be board certified or board eligible. So that's been a little bit a barrier. So but we're still continuing to work with our hospital partners around the state on how we could implement this going forward. So but we took a different approach, which was focusing on group practices, physician clinics, small community health centers, rural clinics. That was more of the low-hanging fruit, and we almost got 40 doctors right now practicing in those primary care areas, which are now serving 35,000 patients. A panel of 35,000 patients, which is super amazing. And we're actually doing a documentary soon about the experiences and the patients that have been impacted and how much of a change it made it on the state. But we do feel that long term this can be adopted in hospitals. We've actually had certain conversations with the American Board of Internal Medicine. The director of academic affairs came to one of our task force meetings to see how we could get IMGs into hospitals under the umbrella of ACGME fellowship. ABIM is one of the best, I would say, medical specialty boards in the country because they are forward thinking and they always want to find ways to incorporate IMGs, and they're willing to actually have IMGs be able to sit for board exams if we can do something under a fellowship umbrella, if that makes sense.
Yeah, thank you. And just aside from the bylaws challenges, have you experienced any other unexpected challenges in your implementation?
Other than the bylaw challenges, no, I would say certain insurance groups, have they see the program differently. Some insurance groups see this program as a fellowship program, as a residency program, and other insurance groups see this program as a full physician, somebody who can bill independently and get credentialed independently. But one thing is that the majority of state Medicaid programs, they see this as a full physician, and IMGs are able to get credentialed and bill under this license. So that is a positive thing. And we're continuing as an advocate. We're continuing to work with different insurance groups. We're continuing to work with different leaders around the country and to make changes. And we're really excited and really happy with the changes that we made so far. I think when it comes to hospitals, each hospital has to take a responsibility to make internal changes if they want to, implement this to their patients, whether it's changing those bylaws, whether it's, creating a fellowship program under this umbrella, like Dr. Karen Smith said, because there's a lot of IMDs who could benefit from this. And I love the data that Jonathan, brought up with the NRMP data. And that is only the IMGs that have ranked a program. So meaning that IMGs who have gotten an interview and have ranked a program. But there's so many IMGs out there who don't even get interviews, right? Because of the competition and, because of the limited spots. And so that number that can even be higher.
Thank you. Thank you for being here and sharing your learnings with us, Dr. Khalif.
Of course.
And now we'll turn to Dr. Casey Salters from she's the Internal Medicine Program Director at the University of Maryland Capital Region Health, and Amy Taloma from Virginia Health Workforce Development Authority, who has been forward thinking about preparing international physicians for this provisional license. Dr. Salters, can you share with us? Yeah.
Yeah, thank you for the introduction. And good afternoon to everybody here listening in on the webinar today. As Brandy said, I am a program director for an internal medicine residency in Maryland, although I did my own residency training in Virginia at UVA. And I am proud to direct a program that is very friendly to international physicians. And primarily my role as a program director is to ensure competence of training physicians before they make their way to independent practice. And specifically, that looks like building curricula or building assessment models to ascertain whether someone is competent to practice independently. And while my work doing that is in the context of ACGME residency programs, my work with RPA has been thinking about how we can determine competence for folks in the provisional license pathway. So when it comes to competence, I know some people on the call here are from teaching institutions and some are not, but just to share this model. So we use this internationally accepted core competency model, which Dr. Smith referenced a little bit earlier when she was speaking. So as I think about the growth towards competence in residents, I consider medical knowledge, which of course is what are all the facts and figures that you've collected over the course of your cumulative medical training. But not only that, how can you take that and apply it to patient care? Because we know that patients are often different than the textbook. So inclusive of that, we also think about communication skills, whether English is or is not your first language, how you communicate with patients who may have a different background than your own, how you communicate with the interdisciplinary team. Professionalism is pretty self-explanatory as an area of competence. And we also consider systems-based practice. That's a term that basically looks at how can you provide high value and effective care in our ever complex US healthcare system and be able to navigate that effectively for your patient. And then finally, practice-based learning, as I think Dr. Smith also referenced, is a physician's ability to query the evidence and apply best practices to their patient care but also receive feedback from whoever's precepting them or working with them, and be able to incorporate feedback into their practice to grow and improve. So again, I think about these competency areas in the context of U.S. resident education. However, we've been in the exploring phase of how to create programming for provisional license applicants to provide sort of a leg up or ensure foundational readiness in these competency areas before pursuing the provisional pathway. Thank you, Brandy, for the opportunity to talk about this.
Thank you. And Amy, can you share with us what the Virginia Health Workforce Development Authority has been doing as a solution partner in this space?
Sure. So Virginia Health Workforce Development Authority has several initiatives. One of them is the Virginia Area Health Education Centers, and those are located throughout Virginia. Really, the goals of the Area Health Education Centers are to really expand, diversify, and transform healthcare throughout the state. And we do this by providing supplemental education and clinical training in clinics that are located in health professional shortage areas. We really would like to support this and aim to support the USMLE prep by kind of looking at other programs and connecting educators, employers, and trainees together. Some of the other readiness models that we're looking at are the UCLA IMG program, the University of Minnesota Bridge program, the Spring Institute Colorado, VCU's Pathway to Healthcare Workforce program, and the UVA Earn While You Learn. We also really are a big proponent of supporting individuals in gaining short-term credentials, as Dr. Hasham talked about earlier, such as CHW or medical assistant, CNAs, et cetera, and really allow individuals to gain employment, but also introduce them to the American healthcare system. We're also committed to providing individuals with opportunities to observe and volunteer at our area health education center locations, which are located in free and charitable clinics, federally qualified health centers, and community-based hospitals.
Thank you both. And I know that we have some registrants from VCU and UVA here. And so we thank you for your forward look thinking about that. And we feel like there's an opportunity to adapt some of those models towards the international physicians in the provisional license readiness. So just a couple of questions for you both. How would the actual clinical experience work? What are they exposed to, and as a provisional licensee, and how would we ensure competence from that? Dr. Salters, do you have some suggestions there?
Thanks, Brandy. I think it would depend on the host institution, whether that's a hospital, whether that's a clinic, and identifying what the needs are within your community would probably shape what the clinical experience looks like for the provisional license physician. And in terms of ensuring competence, as you've referenced, I think, and I think Dr. Smith referenced, this competency model is easily adaptable and can be applied at multiple stages of learning, whether that's someone who is a beginning resident or someone who's a fellow or someone who's equivalent to a fellow. So I think there's a lot of work we can do and discussions we can have about how to adapt to different scenarios.
Thank you. And one question about training for the supervising physicians. Is there anything you'd recommend for them?
Yeah, I firmly believe as a medical educator, of course, I am biased, but I think that all folks who are precepting learners, again, wherever they are on the pathway, need some basic training in how to supervise adequately, and then also how to assess for these levels of competency, both efficiently and effectively.
Thank you both for your innovative work and for thinking ahead about in this development phase. And now we'll hear from Dr. Stephanie Goldberg from Mary Washington Hospital to share about what medical institutions can do now to prepare.
Good afternoon. Thank you for having me. I am a Vice President for Graduate Medical Education at Mary Washington Healthcare and have overseen the transformation to a community teaching health system. And as we've gone on this journey, one of the things that has become very evident is that there are a lot of people in all of our communities who fall into this category and who have a lot to provide and contribute to our healthcare within our communities. So as the Board of Medicine meets towards the end of January to hopefully finalize what the plan will look like, the task force is working on recommendations to help figure out how to implement this program. But in the meantime, there's a lot that you all can do to help prepare. So first of all, look for early adopters within your institutions, train preceptors, and work with your GME or educational offices to really help try to lay the framework for what this program could look like. In addition, start supporting and looking for people within your own communities to help either get them into the healthcare system and employ them in other roles, support other clinical roles, help them pass their USMLE so that they can be prepared to step into a provisional license role sooner rather than later. And as someone alluded to earlier, there's of course the approach that we're going to take towards how we train, evaluate, or how we evaluate and assess these physicians while they have their provisional license. But the next layer of this is, what does the pathway to employment look like for them in the community? And we had spoken a little bit about how some hospital bylaws may require board eligibility and so forth. There are things that we can do as healthcare systems to look at where these physicians can function without having board eligibility or board certification, and potentially look at our bylaws within our organizations to see where we might be able to add some waivers or some revisions. And of course, those things take a long time. So that's something that I would definitely recommend you look at sooner rather than later. But on that note, this is a very exciting program, and interested to see what we can do to help support this moving forward in the state of Virginia.
Thank you, Dr. Goldberg. And just to let you all know that the Refugee Physicians Advocacy Coalition is remaining engaged with the Board of Medicine's rulemaking process to provide input at those committee meetings. Their next meeting is in January, but we anticipate that this will take about a year. So we will continue to follow this closely and provide input. Our hope would be that we could have some implementation development happening parallel to that process, so that we don't have to wait for the board to finalize the rules before we have hospitals starting to look at preparing their institutions. So we've given you a lot to think about today, and we invite you to think about this. And if you have more questions, please submit your questions in the link. And it also has a place to opt in as a task force member. So we're looking for institutions to be early adopters and those who would be willing to take part in the Provisional License Task Force Roundtable. We'll have that scheduled for February 12th at the same time. And that will help us determine what is important to prioritize first in the implementation development. VHHA, RPA, and medical institutions can help develop the institutional implementation for provisional licenses while the Board of Medicine does its work. And so we invite you to participate, and even if we, just are helping to address the questions that you have and thinking about the different levels of institutions that there are: private clinics, private hospitals, and state-run hospitals. So we ask you to save the date. Also, it was mentioned that we have international medical graduates who are approaching us for support. Some of those who are refugees are not even working in the medical space right now, and it's difficult for them to take the time to study for the USMLEs. It's not that it's too difficult for them, it's just it's difficult for them to dedicate the time and the finances towards those studies and those exam fees. So we have about 120 doctors through international physicians in our network that have come to us for that support. And of those, about 20% do qualify currently in our numbers qualify for the provisional license. That means 80% of them are available for other open positions. So our next webinar session is will be helping to address those open roles in your healthcare workforce and making suggestions about how to ready this group of doctors into those open positions and to grow your health workforce. So save the date for February 26th at the same hour and invite those on your teams who it might be relevant for them to participate. I'll be sending out an email next week to those who have registered for today's webinar. And I'll share with you some sample profiles of international physicians, about 8 out of our 120. I'll send profiles to you. We'll have links to their CVs so that you can see the quality of candidates that are eligible for this license, like Dr. Gospodinov. And we'll share those as well as the recording to this webinar and the slide deck. I'll share it with you next week. And I should let you know that of those 120 doctors, we've surveyed those, and many of them are willing to relocate. I noticed that of those of you who have registered for today's webinar, many of you are in outside of the DMV area. Many of our doctors who are part of our network are in the DMV area, but they are willing to relocate into your open roles. So thank you for joining us today, and we look forward to working with you to develop this further.